our energy and put it to good use. Okay, so 10 seconds. Same format.
Hi guys, thank you for joining. This is Amanda Armagoss. Today, we are going to be talking about the future of spine surgery.
I'm Dr. Abbasi for Essence, and again, my pleasure to have a pioneer in this area of the spine surgery, my friend and colleague, Dr. Robert Masson, who are going to help me to discuss what has been the past of the spine surgery and what the future of that going to be. Please, Robert, tell us a little about what qualifies you to talk about this topic.
Yes, sir. Yeah, my name is Robert Masson. I'm a neurosurgeon in Orlando, Florida, primarily. I also have a practice in Park City, Utah. I was trained in fellowship as a cerebral vascular and skull-based fellow. Albert Rotan was my mentor, my chairman. Rick Fessler was my spine professor during residency training. So I grew up with a strong, rich, innovative push in cranial and spinal neurosurgery. On the other hand, minimally invasive techniques in spinal surgery in the early 90s really meant one thing. It meant tubular surgery. It meant this little metal tube that at the time was microendoscopic discectomy with actually a camera lens at the end of it. And that tube became the basis for 25 years later, what a lot of people still call minimally invasive spine surgery, but there's so much more to it than that. But we were one of the IDE sites for that training. I founded the Masson Spine Institute in 1999 in Orlando. We built surgery centers in Orlando and in Park City, Utah, that are independent and wholly owned by us and part of our community. And the entire journey has been to try to propel minimally invasive spine surgery and simultaneously and in parallel a culture of rapid recovery, early mobilization, sports spine surgery. I've always had an aggressive passion about functional purpose for spine surgery, not the classic disability-minded spine surgery. So all of that has been collaborated into how I have chosen to push my spine surgery career.
Certainly, you had a massive career behind you with being in places where the neurosurgery have been being pushed forward. And we are going to talk today mostly about the future of the spine, but we cannot go talk about the future of the spine without talking a little about the past of the spine. Now, one of the things that I notice is that the standard of care today is still a procedure called PLIF, posterolateral lumbar interbody fusion, or TLIF, the transforaminal lumbar interbody fusion. And please bear for viewers that are not familiar with that, we have other sources that you can go and educate yourself about that. But Robert, it was lots of people don't know the PLIF and TLIF. They are 1950s and 1980s technology and standards, and
right.
And 40 years later, almost 70 years later, we are still driving the cars that are 70 and 40 years old. Tell us a little about this. When do we start treating the spine, and what are the options? What did you learn in your residency, and where we are?
Yeah, I think the fascinating thing about spine surgery is, to me, it even starts without the technology. So I'm going to go back to diagnostic spine surgery. Most of our treatments have been built around the method for diagnosis in the 70s, the CT myelogram. There was once upon a time the CT scan came to market, and it was going to show three-dimensional information and computerized data built around dye injected into the spinal canal. But what does that fill? It fills literally the central spinal canal. And turns out like 80 to 90% of real pathology is actually not in the center, but adjacent to the center in the corners. And the vast majority of procedural neurosurgery was built around CT myelogram. And so everyone attacked the spine from the midline and from typically posterior. And that dives right into the dura, right into the nerves. And even central stenosis is usually lateral to medial and then influenced by front to back. But even front to back, you have to go around to get to it. So you still want to be lateral. So right off the bat, coming in the 90s, the entire industry was focused on a posterior midline approach. So that standard for access was part one of the puzzle. Shortly thereafter, the abdominal approach came to pass, and I became part of the BAK and Ray Cage Rage and of the mid 90s, and was an educator there. I was an educator for the original PLIF. We were doing all sorts of crazy things with onlay fusions. It was big open. We were doing tubes for the decompression. So the other thing about spine surgery is way back then, it was this or that. It was a micro decompression, which could mean microscopic, could mean open, or could mean tubular. A lot of open was at the best hands loops, but that was considered minimally invasive. And then there was the big bad reconstructive surgery. And there was so little emphasis placed on minimally invasive, minimally destructive, least deconstructive methods of reconstructing. And so that was really where I found influence and passion. And I attacked reconstructive surgery with the same energy that the people I worked with pursued minimally invasive spine surgery, which meant one thing: avoiding reconstruction. Even recently, I did a keynote at the International Federation of Neuroendoscopy in Orlando in 2019, and it was to hybridize endoscopic, which is the latest version of the minimally invasive decompression crusade, versus reconstruction. My talk was about endoscopic reconstruction and the opportunity to bring yet another brilliant evolution of visualization technologies to a less disruptive reconstruction strategy. It's not this or that. It's let's use best technologies to accomplish best solutions, depending on what that person needs and why. And that what they need and why is probably the biggest variable in spine surgery. If you talk to 1,000 surgeons, you'll get 1,000 answers of who do you fuse, who do you CDR, who do you decompress, who can't you decompress. I decompress people who can't be decompressed all the time. I reconstruct people that people are scared to reconstruct all the time.
Many of our viewers may not know that, but or may have the question. So for a long time, everybody is concentrating on the posterior, meaning from the back approach, cutting everything, opening up everything. And some people may ask, so what's wrong with it? Why not? Why find another solution to traditional posterior approach that always has been thought? So what would you tell to people? Say, why look for a new way?
Well, it was done. It was a new way once upon a time, but it didn't really advance, and just because it was comfortable didn't make it best of possibilities. So when I actually went through, TLIF, PLIF, ALIF. I had my own lateral. I did my own transpsoas lateral approach in 1997, 1998, and 1999, and I was this close to being involved in the XLIF development project. But I recognized that there were still these random episodes of severe dysesthesia and lumbosacral plexus problem that when they happened, you had no idea why. You knew it would get better, but it didn't hit the target goal of rapid recovery, early mobilization. Those people were miserable for 3 to 6 weeks. And it didn't matter that they got better because the goal was rapid recovery, early mobilization. So, and then, ALIF was complicated. You had to have general vascular support usually, and depending on liability of your state, you had to have that. And it just wasn't simple. And honestly, I also started to feel like spine was starting to become segmental. Like let's do this approach to put in screws. Let's do that approach to put in a cage. Let's do this approach to do the decompression. I don't think that way. I'm a symphony guy. I like to come up with one approach that hits all objectives. You can compromise one or two of the objectives a little bit for the symphony benefit, because the symphony is more important than the sum. The whole, if you're a whole is bigger than the sum of the parts kind of person, then you like the symphony approach. If you really want 3 surgeries to accomplish 1 surgery, technically you can have the 3 best surgeries.
But I love what you said, that the posterior approaches are simple and easy for the surgeon, but not necessarily for the patient. For lack of other term, posterior approach are easy on the surgeon because you fillet it open and you have the direct view of the entire anatomy. And we don't do that to our patient, but we don't reattach those muscles. As a matter of fact, we take the part of the bone that the muscle attached to, we take that part out. So the muscle has nothing to be attached to. And if you come back 6 months later, all those muscles are sore.
I'll go one step further. The most destructive thing about posterior midline approach is the old-fashioned laminectomy. Not only are you removing where the muscle's attached to, you're literally removing the thing that the muscle's attached to. What does that do? It also takes interspinous ligaments. It also forever affects the flexion extension dynamics of the disc level above and below. People like to assume that it's the surgical fusion that causes adjacent level disease. I aggressively disagree. I think it's the disruption of the adjacent, stability structures, the cable system of the Golden Gate Bridge, if you will. The posterior architecture is critically important. I think I still do a posterior midline approach, but the problem is you can do that like this, or you can do that like this. You can do that with complete disrespect of the musculature and total devascularization and denervation of the midline, or you can do a bilateral fascial split and obliquely. We all were taught 90-degree cuts in everything. It didn't matter what we were doing. It's a 90-degree box. You can start a finger breadth off midline, transfascial, split into dorsolaminal arch. There's no vascular bundle down there. All of that's a spinous process. So if you spare that, you're golden. You still have propulsive capacity of paraspinous. So it was just about learning the tricks of muscle splitting, not muscle destroying.
So, Robert, you're so passionate about that. I have to dissect it a little for people who are not spine surgeons. You were referring to adjacent segment disease, meaning that we do a surgery for one level, and we know many of these patients years later, or sometimes months later.
25%, 10 years allegedly.
That is that the next level goes bad, and that is saying that spine surgery begets spine surgery. For a long time, we didn't understand what's going on. And some people say because you did a spine surgery, it's getting bad. Some people say, no, it's just the aging process. 10 years later, something else is going bad. But I think the truth is in between, is aging process, but more importantly, the way the first surgery. If you are destabilizing one segment, this muscle in the spine are multisegmental. As a matter of fact, I go and give this talk that if you do a surgery on one level, 2 levels above, the inherited muscle of the spine, we call that multifidus muscle, they turn into a scar. By avoiding that you are setting your patient up for more success or for less success. And that is, I think, what you were referring. But as well, the idea that you are describing, that we learned to cut the muscle in certain way, but there are better way to cut the muscle, not to practically destroy them completely.
So people criticize the fact that I use real-time dynamic fluoroscopy. Dynamic meaning constantly throughout the case. And what that affords me is 70 to 80% of my surgery is no retractors in the wound. And what does that translate to? That's not about the spinal cord. That's not about the nerves. It's not about the bone. It's about the muscle. What is the single most important factor to physical performance, functional capacity, adjacent level disease? It's damage, death, and harm to the musculature of the spine. Even if it's present, if it's not functioning, if the proprioceptive capacity is gone, your body doesn't know how to protect itself. And the more trauma you cause, the less mobility, less flexibility of your hips, your hamstring, your knees, your feet, your ankle. Well, what does that do? It increases torque and stress on your lumbar spine.
Yeah.
So that problem begets other problems that feed back on the primary problem. So, how we do things matters a tremendous amount. And I feel like I'm at the tip of the iceberg in terms of understanding, and yet the industry still is so far behind.
I agree with you. 80% of the surgeries on the lumbar spine for fusion are still performed the way that you and I discussed is not the best way to do it. Now, maybe they were good 40 years ago, 50 years ago, 70 years ago, but we have so many better options, and yet 80% of those surgeries are still done that way. What do you think? Why do you think people, I know that you mentioned before that you don't even go and start talking to people. They have to come and watch it. But when I go and present that, people who have 10% risk of infection, they tell me I shoot 2 more X-rays. Am I concerned about 5 more seconds of X-rays? Where I have 0.2% risk of infection. Now, it is sort of like, to put that in perspective, but tell me about you. Why do you think that it's people make it so difficult to move to the next step? Because the next step is already there. You are doing it.
This is difficult to say in a way that doesn't offend some people, but healthcare as an institution.
Eggs and omelets. Eggs and omelets.
The harsh reality is it's very, very difficult to transcend healthcare dogma. And it's a very conservative, very historic, very traditional structure of how one proceeds in navigating healthcare innovation and the push. And I love Blalock Taussig Shunt as an example, and the Blue Babies and Johns Hopkins Hospital way back when. Imagine all the stuff that they had to go through to learn new procedures. And I did a keynote in London at the Percival Potts Orthopedic Society in 2018. And my talk was on this concept, actually. And there were literally names of dead surgeons carved into the backs of chairs at St. Bartholomew's Hospital, where I did the talk. And that was an ominous sense of tradition. And so I actually left there humbled and respectful of the need for that tradition. On the other hand, we're not encouraged, nor are we trained to transcend this simple little phrase. It's this really, really damaging little phrase called the standard of care. It's funny, before I went to med school, every person I knew who was trying to get into med school was trying to be in the top 2% of their class. All of a sudden, you finish medical training and you're expected to be at the 50th percentile. A little weird. It doesn't make any sense, honestly. To me, standard of care is average. It's middle of the curve. The tip of the spear is pushing forward, and then there's that whole transcending curve towards pushing forward. But you have to do it safely. You have to do it responsibly. I think the process for innovation, the process for the push, is as important as the push itself. You can't be a cowboy. The people that would have rebounded at the lectures that I refused to give in the 2000s would have used the word cowboy. They would have used the radical new procedures without evidence-based protocols and blah, blah, blah. Harsh reality is my process was so micro expression oriented. You would change one tiny detail or one tiny sequence or over and over and over. And the beauty about a segmental approach like you're doing is you do the same thing over and over with little micro expressions of advancement and change. And you recognize immediately this helped, or I'm going to subtract that. And you add and you subtract, and you add and you subtract. And it's really monotonous. And there are times where I almost wish I had chronologed and data recorded all of those micro expressions, so I could really repudiate the dogma that's just thrown out about, you know, the obvious immediacy of transcendence. But it was never immediate. It was so unbelievably invisible to anybody watching. Nobody in the room would have understood that I drilled this way instead of that way. I drilled that bone, but I stopped earlier, or I went a little farther, or you know what, I drilled ventral, but I didn't drill dorsal. You know, maybe that medial facetectomy thing we all talk about is when you're talking about 90 degrees. Maybe if you're doing it inside out, maybe you can do a little more deep. Where does it need to be? Usually deep. So there's all this dogma, and there are so many ways to challenge it, but it involves nuance, it involves subtlety, it involves technical capabilities, precision, dynamic imaging. You know, I don't mind advanced nav. I just wish it was being used and developed for harder parts of spine surgery than pedicle screw placement. That's the easiest part of spine surgery. I mean, nobody holds, you know, for all of the garbage you hear about, and I'm going to be aggressive here, about, accuracy and nav for screw placement. That's ridiculous. If that were the case, then why are we still doing vertebroplasties and kyphoplasties with fluoro? I would argue the medical legal tolerance for a kyphoplasty gone bad in a 76-year-old thoracic spine vertebral body compression fracture is 0. And yet somehow we navigate those tiny little pedicles with cannulas all the time. And yet we have to have nav. So that's just garbage. That's just, you know,
Well, Robert, let me tell you something about my background. I did a PhD in computer science.
Right.
I literally built those machines.
Right.
I was in
Good.
Stanford.
Yeah.
And now when people are so sold on those skills, that shows just their blindness to the reality. And that's something Amanda is going to take a smile or a laugh out of it. You are using navigation. You're using the best navigation in the whole world. And you are using a robot. You're using the best robot in the whole universe.
It's called biological robot.
Yes, your shoulder. And people, I wrote those algorithms. I know how prone they are to mistakes. That it's not rare that I have heard people putting 2 screws in L4, that they are so far off, because people who understand least about this technology, they are more sold on it.
Right. Well, one of the problems with it is you really have to be an expert in not needing it to know how to use it best. And unfortunately, it's being trained to replace traditional.
Absolutely. Not complement, but to replace the skills.
Exactly.
Now, I was in a meeting, and one of the major, universities, the surgeon was saying, we don't teach them open surgery anymore. And I really wanted to hit my head against the wall. They are not teaching the resident to do regular surgery anymore. Right. And that person was saying that maybe we should send them to Africa to learn the open surgery. No, you don't need to send them to Africa. You need to send them to lots of people who are doing at much higher level than you guys. The surgery every day. But you cannot teach them to replace the skills with the technology. Certainly, that is one of the future of the spine that I don't agree with, not based on me not liking that, because I'm a programmer. I use those programs.
Yeah.
I know where the damage come from when we go that route. Please tell me about your experience.
No, I mean, everything you said, I mean, my immediate thought is great minds think alike. I love technology. I love innovation. I celebrate it. I actually can justify use of nav for screw placement, understanding the relevance of further development from the tech standpoint, so that someday we'll be able to use it for more advanced features. And that's phenomenal. On the other hand, what always happens is sort of a passive, lazy approach to insertion of tech. And instead of a diligent this enhanced by that approach, which requires more effort, more work, more skill, more mastery, ultimately more time. And guess what? The most important piece of the puzzle, it's not reimbursable time. It's we live in a commodity-based surgical paradigm, and if it's not reimbursed, you lose a lot of the motivation, if you will, to spend the proper time educating.
Let's talk about some words that people sometimes have heard. Like many of my patients come to me and ask me about, doctor, do you use laser spine procedure? What would you tell to them about? Let's go through certain things that myths and rumors and so on. What do you think about laser spine surgery?
Well, you have to remember that I'm in Orlando, Florida, and Laser Spine Institute was about 64 miles away. And so I've seen tens of thousands of people who, were wrapped in a little bow with wrapping paper from Laser Spine to come to Orlando and have me, talk to them. And, to me, it's easy. I use lasers when I was a neurosurgeon doing cranial skull base surgery. It's a tool. It's a tool like every other tool we have. We have all sorts of amazing tools. And, and sometimes tools are marketing gimmicks, and sometimes they're actually relevant. In spine surgery, the thought of burning away a piece of bone, a cubic centimeter of bone, or burning away a calcified disc, or burning away a spur with a light source is almost comedic. It's ridiculous. And the bottom line is there are better ways to do the same thing. We have lots of tools that can remove bone. We have curettes, we have Kerrisons, we have pituitary rongeurs, we have 85,000 RPM electric drills, we have pneumatic drills, we have ultrasonic bone management systems, courtesy of Masonics, and their successor, and you have light sources that get incredibly hot. Well, guess what? I really don't want to burn it to bone hot right next to a really important dorsal root ganglia. That might be a really bad idea. So, it's just a tool. We can also use heat. We can use Akusa. We can go to, it's a tool.
There are lots of options.
Yeah. So, I think at the end of the day, the surgical healthcare industry wants to remove the craftsmanship component of what it means to be a barber, what it means to be a surgeon, what it means to actually physically manipulate the human body for best healthcare possible. And we are nowhere near losing the importance of the mastery of the human who's literally learned tried and true personal techniques to influence somebody's future. And that's the art of surgery. And those tools don't add anything to art.
I was as well, obviously, I think that you and I agree on that the laser spine is in the past of the spine, is not in the future of the spine. Now, I have been in some, Amanda, and as well, I want to know your opinion on that. I was in a conference where somebody was showing his 11-year-old son on one of these robots and so on, and doing on a model. And he was saying that the spine surgery with the robot is so easy. My 11-year-old son can do that. And I was horrified myself. But how do you feel about about that picture that he puts up, that the 11-year-old is working on as a patient, I know your family has some spine problem. There is barely any family doesn't have spine problem. Would that suit you, or would that be scary to you when
honestly, it makes me, I don't actually get affected by it in a negative way because I think it's ridiculous. It's almost comedic. I mean, it just grossly demonstrates a complete lack of understanding of the subtlety and nuance that we have to manage. And I've seen your cases. I know you deal with this all the time. I certainly do. We get so many situations of failed surgeries where you just look at it and you hear the story and you hear the symptoms and the provocations and the mechanical, details of their story and how it evolved, how it progressed. And you look at the spot that fits that spot on the MRI and it's like, well, they didn't hit the spot. There's so much more to surgery than just the technical execution. That being said, ironically, so many spine surgeons could still improve their mastery of the technical component.
Yeah.
But I would argue that that opportunity is even less than the opportunity to improve their diagnostics.
Yeah.
And like, for instance, we have a skelototopic perspective of how we think of nerve root entrapment. So, L5 radiculate, L4-5. Well, L5 typically is somewhere above the disc space at 4-5, up and over the disc space, down around the pedicle. If you have a hyperacute laminar interface, it might get pinched, particularly if there's an inferior bulge of the disc around the pedicle, exit zone L5-S1, maybe a high SIP, ISP, cyst that's hitting the dorsal root ganglia from low. If I have a complex L5 radic, I want to see the whole damn thing.
Yeah.
And
so once in a while, Robert, I become a little, I want to play around. I put a picture in LinkedIn, and there are two groups of surgeons like you and I. Some people go and ask, what are the patient's symptoms? What bothers the patient? But then there's another group of people who look at one picture. They know exactly what kind of surgery they are going to do to make the picture, to fix the picture. But so I like what you said about that. Is it the L5 nerve root? Where is the pain? Where are the symptoms? When did we stop being clinician and became technocrats, the mechanics that we fix, or Photoshop engineers that we just make a picture that we make 7 degree to 11 degree, but what is the background to that? When did that happen?
Well, it's funny because as you're describing that, it occurred to me the 11-year-old and the robot, why the 11-year-old can do surgery because it's become technocrat, because it's if this then that. And again, it's a fundamental lack of understanding and a lack of respect for the subtlety and the nuance and the precision and the diagnostic opportunity in spine surgery. I would still argue, people ask me all the time, what's the best next spine surgery innovative tech? My answer passionately is diagnostics. I don't need more tools. I mean, I could go a few more lifetimes without tools if someone would gift me best of class anatomic diagnostics. And the problem is we haven't maximized MRI. Let's, if you don't mind, I'm gonna go on a little passion play. About 12 years ago, I chose L5 as the route I would follow because it's, in my opinion, the most common radiculopathy in any spine surgeon's practice is the L5 nerve root. That's 80% of all cases. So I picked a local MRI facility and I decided we're going to go for a neurotopic approach. We're going to go XYZ coordinate on the L5 nerve root, not on the spine. Right now, MRIs are done XYZ segmentally on the spine with coronal plane, sagittal plane, axial plane. We specifically focused on the L5 root above the disc space, at the disc space, 2 millimeter cuts, all the way to the exit zone in L5-S1, but with the Y coordinate oblique relative to the skeletotopic perspective. We could see edema and ischemia patterns within the nerve root. We could see dents in the L5 nerve root from ligaments attaching. The facility ultimately declined fulfilling that project anymore because they couldn't get reimbursement for those MRIs. So here we had a transcendent way of looking at complex L5 nerve root pathology, but it wasn't a normal MRI. Therefore, it was subjected to a denial of payment. So they had to say, sorry, Robert, we can't do this anymore. But I mean, that presumes that XYZ coordinate and MRI and CT imaging is the epitome of diagnostic capacity with advanced computerized digital imaging. And we haven't even scratched the surface in pushing that boundary. So that's a failure. That's something that I've wanted to push. I've tried to push. I have talked to GE in Salt Lake City. I've talked to Siemens. I mean, Damadian, I know people that know Damadian. I can't get anybody to look at the way we scroll XYZ coordinates in imaging systems. Think about that. Think about the power of what I just said. It's
absolutely. Now, certainly the diagnostic has a lot to go, especially with the new technologies, especially with the new, I see, you are very involved in the computer technology, in the AI and so on, and so are we. So there is so much to learn here. And it just pains me. The people who are pushing that are not people like you and I who are inherently involved. We know what we need. You have to let the pilot decide the modification to an airplane, not to somebody who has never flown the airplane.
Yeah.
But yet the industry, who has never taken a call from a patient who has back problem, leg problem, is pushing these blind technologies. So let's talk a little about as well. A spine problem is a very common problem. Like, Amanda, you found out there are lots of spine surgeries are done in the United States. What did you find out about the volume and the prevalence of the spine problem, Amanda?
It was in 2021, but I saw that 1.62 million spinal fusions are performed each year.
And you found out as well, I believe, that that's number one reason for disability in the whole world. So this is a public health issue. This is not a rare disease that 100 people have it. Right. And yet there's so much we don't know about that that even the joke that if you mentioned that there are so many opinions, but not really enough evidence. It's more eminence-based medicine than evidence-based medicine. Right. But I think, considering how prevalent spine problems are, that these new technologies that you are working on, like AI and so on, have a huge potential for future of the spine to unify our approach to that. Now, I want to hear a little about the way you are using the new technologies in your treatment of the spine, but as well, I will tell a little about what we are doing. I think we are on the same path. Please go ahead.
No, I would love to hear more about yours, actually. I actually decided on my journey to focus on surgical organization and logistics. The problem we're attacking is disorganization, not because great teams don't try, but because great teams do try, and they're using methods and processes of the 1920s. A little scribble pref card isn't really adequate for modern day organization strategies. Needless to say, predictive analytics and sequential symphony style surgical monitoring, best practice analysis, everything else. So we're really looking at it from a surgical ecosystem perspective in my current project and my current company. And I'm laser focused on that. So one thing, my OCD helps me stay focused. I have a lot of ideas and they're touching on what you alluded to, but I'm really laser focused on the logistics of the surgical episode of care times every surgical episode of care. I have strong opinions about AI and diagnostics. I think it would be incredibly powerful to have an AI engine. Personally, I don't mind sharing this. I had a prostate biopsy last summer on an AI intermediated MRI scan, and it was ultimately MRI directed based on all of the parameters of that AI interface. The beauty of that environment, it was very, very slick, and probably one of the slickest protocols I found globally in the case of what I was dealing with, and personally, and I loved it. But they had a closed system. It was not an autonomous AI. It didn't invite everybody to the table. They had a very, very regimented and architected and specific, info in, info out. The problem with AI and something that people who don't really, as a computer science background person, you understand the value of the quality of the data in and the quality of the data out. Too many people just think it's just, it's AI. No. I mean, imagine the herd effect. Imagine all the people that are still doing 1970s and 80s and 90s style spine surgery being the ones who decided on the input to the diagnostic algorithms. You get the same exact answer back from the artificial intelligence that you would from the biological intelligence. And really, AI is an extension of the human experience.
That's right.
So if you train it in modern opinions, you're going to get a different result than if you train it in pre-modern opinions. So I think it's really going to be tricky to clinically bring AI unless you can create large groups of really progressive surgeons to agree on rules of engagement for how to structure the conversation. Because if it's truly egalitarian across the whole herd, that's where hallucinations happen within AI. That's where you get these random opinions in 27 different directions, because it's learned all of those opinions and the basis and the dogma and the background and how they got there. And again, it's so much that we contend with is irrefutable to the person with the data.
So I think that's yet another area that you and I agree that AI is the future, but right people have to create that AI. Not every AI is the same. We talked about that the laser is past of the spine, not the future of the spine. And I think you and I, we both agree the way you do the surgery, especially preserving the muscle in the back of the spine, is the key to future of the spine. But let's be a little more specific. I want to know, I see on your background that XX. I want to know more about that. And I'm sure lots of people are interested, first of all, what that is, but as well, you have developed your own method of doing a spine surgery. I think I personally want to really know about your method and eventually I'm going to come to you and watch it. But I want to know a little more about, because I see that as both of them as a future of the spine. And spine surgery, it doesn't exist in vacuum. Logistic, the whole room, the whole team is part of that, doing that. But tell us, first of all, about your method of doing the spinal fusion. What is different about it? And then as well, I would love to know a little bit more about XX.
Yeah, no, and honestly, that's the right sequence, because people that want to put me in the box of, so he's leaving spine surgery to do XX, don't understand that it's the evolution of the spine journey, because my commitment to the spine journey was more than just the microsurgical anatomy. It was the sequence. It was the symphony build. It was the attention to detail about angles of attack, precision, focal endpoint, dynamic navigation, direct microsurgical visualization. There are so many pieces of the puzzle, but IMAS is the procedural solution I did. You can do each detail of a typical IMAS case or a lateral transcambent approach. You can play with the subtlety of the angles, but the real art is the sequence, the movement, the efficiency, the using one piece of the procedure to assist another piece of the procedure. You're not doing segmented pieces of the procedure in a vacuum. When I really started with IMAS, it started really very simply. I had a 83-year-old woman with horrible degenerative scoliosis that had 4 previous decompressive surgeries for a critical L5 radiculopathy. She was in agony. She was narcotic dependent, spinal cord stimulator, 5 previous spinal decompressions. Nobody touched the pain. And she was shipped to me, and I very cavalierly said, it's right there on the MRI, and I can see it, it's plain as day. Saw the incisions on her back when I positioned her on the table. Her vertebrae were like ghosts, literally. You could barely see them. So in fairness to all the people I emotionally criticized, it was daunting. She's asleep, she's on the table. And I was like, all I can see is a shadow of the pedicle. And this was in 1998. And Clix was around. I had helped develop a headless pedicle screw system where no head was there. So I asked for one of those screws, and I found the ipsilateral L5 pedicle. And I said, okay, I can see that. And I got in the right plane, and I dropped a headless screw down that plane. I then put my incision over that. I chased the buoy. The buoy was the L5 screw. I found the pedicle. I said, well, if that's the screw, the foramen's right here. There was no scar anywhere near that foramen. And it was a big lateral recess foraminal compression. So bottom line, it immediately became obvious that a well-placed headless pedicle screw, strategically oriented to all the other spinal anatomical parts, was a buoy for other pieces of the puzzle of the
Yeah.
procedure. So anyway, that procedure took 20 minutes once I placed the screw. And she woke up with tears because for the first time in 3 years, she had zero pain. And that was the beginning of IMAS. And it had nothing to do with reconstructive surgery, but it occurred to me on revision surgeries and revision reconstructions where you're navigating the big open laminectomies that had been done before. Everybody would dive into the dura instead of go lateral to medial. I was like, well, why do we do that? One reason was because screws were put in last. Well, maybe if we change the sequence and put screws in first, headless, now we have a buoy system and we know where the facets are and we can go from lateral to medial. And the so-called Masson keyhole, that was 1999, 2000. I mean, I forget that more than I remember it. That was built around the pedicle screw for complex revision anatomy. I got to a point by 2002 where with banana structural machine allografts, Klix headless screws, and this really rudimentary early IMAS approach, my revision surgery patients were leaving on post-op day 1, 2, and my primary brand new ones would be 4 days in the hospital because I hadn't changed my first time surgeries yet. I had built something for revision surgery. And so that was the pivot. When I realized that, I immediately started applying them to first time surgeries. There was no rule book for revision surgery, right? We're all very comfortable. You talk about process and how you get to a solution innovatively. Well, it's usually in the god-awful situations that you pick up your best tricks because there's no rule book for those surgeries. So once I knew my revision patients were doing better than my new patients, I just gently assimilated into my news. And then we worked with Synthes. We developed the second generation of the cage, the system, the steerable, the screws, and wasn't happy with that. Migrated to DePuy, but all of that architecture, it was sequence, it was accuracy, it was diagnostics, it was lordosis, sagittal balance. I had already gone through around the world with interbody, anterior, posterior, lateral. The only thing I never tried was the transrectal. I'm okay with that. But I came back to Jürgen Harms and I went and spent some time with Jürgen Harms. And I was like, I think that's brilliant. For me, I landed on the TLIF and I decided that I was going to pick that because of the screw, because of the TLIF, because of the midline decompressive approach. It accomplished all my boxes, and I thought there was a tremendous amount of room for precision and improvement. And I focused 100% on improving every detail of that approach. And to my deathbed, I will always celebrate Jürgen Harms because I do think when he did what he did, particularly, thinking, in through the outdoor, old Led Zeppelin song, but coming in from lateral to medial, lateral transfacetal, that was brilliant. And it was without advanced imaging and it just needed to be modernized. And so that's how
he got lots of critic though at first, like any other pioneer, he got lots of critic about, what he was doing.
Absolutely.
But then everybody turned around and did what he did. So that is, but I think what's as well important, what I hear from you, that, this meticulousness, this obsessive compulsiveness to take a process apart and see what you can improve at every level. What has enabled you to be one of few people who did these complex surgeries in an outpatient setting. There are very few who are able to do that. And because the amount of the damage we cause doing the surgery, that practically is prohibitive to do that in a surgery center. But I think you just described the steps that you take to reduce the trauma of the surgery itself to be able to do that. Now, how was that transition from doing these surgeries in the hospital, patient stays a whole week, to surgery center where they go home same day?
So that part of the journey, I had to go through the old-fashioned way because we were first movers. And so I talked to you earlier about building the JCO Spine Center of Excellence. So part of that process was to build clinical pathways for preoperative care, perioperative care, postoperative care, physical therapy, walking day of surgery, optimizing anesthetics and minimal anesthetic concentrations and how we played with medication. So that journey, trying to get a hospital from, and this was before there was a standard for a spine center of excellence. So my theory was least invasive care afforded us the opportunity to mimic what? To mimic what orthopedics had already done. When you looked at, I actually chase mentors. So Jim Andrews and Dick Stedman became mentors of mine. And I was relentless and I nagged them and I showed up and I bothered them and I, learned about their arthroscopic orthopedic journey and all the pushback from the traditionalists and, oh, this is garbage, it's a gimmick, it's a blah, blah, blah. Eventually they figured out it wasn't about the tool. It was about the culture of early mobilization, rapid recovery. Who was first to outpatient surgery? The orthopedists were. Why? Because they had long since pivoted from traditional massive orthopedic performance. Anterior hip is another great example of another transcendence within orthopedics. That one was slow. That one was more like spine surgery. So anterior hip was being developed by Joel Mata out in California at the same time that I was pushing IMAS. And we became kind of aligned in our thinking. And we both were DePuy consultants and innovators at the time. And so all of that hospital-based stuff, we started realizing, wow, these people don't need to stay in the hospital anymore. But we were still encamped at the hospital. And that's when I decided to build my surgery centers. And
lots of people don't understand that to be able to do this surgery in the surgery center, it requires a fantastic team. We know the result of the spine surgery in the surgery center are so much better than in the hospital. Now, some cynic people say, oh, that's because you take only the easy cases to surgery center. Your example that's not true. But what they don't understand. What I think that is very important here is that now there is certain kind of people who are obsessive compulsive enough, who take the processes apart enough, who understand all the aspect of that, even dare to take those cases to surgery center. I would agree that your result would be better no matter where you do that. But the reason you choose to do it in a surgery center is because that is the place where you can put your best team together.
It's the infection rate's lower. We're not managing sick people. When you go through a committed, regimented, redundancy built process, you learn the reliability, the probability sequence. And, spine surgery at large still lives in a high risk profile category. But when you go several thousand cases without, it's funny, people say, what's your screw accuracy rate? We haven't had a missed screw in 18 years. And that was in a half pedicle because it was a fourth time revision and half the pedicle was already gone, and it was breach of the lateral, it's not do you miss, it's why do you miss? It's, what are the circumstances? You get to a redundancy level and a precision level and an expectation level where every piece of the puzzle has so much background that it's not about the surgery that you're worried. What is a high volume spine reconstruction surgery really practically worry about? They worry about wound infections. They worry about DVTs. They worry about pneumonia. They worry about urinary tract infections from a Foley too long that ultimately lead to some subcutaneous infection and osteomyelitis. They worry about, all of the drug mismanagement problems, patients getting behind the pain cycle, getting too much pain medication, the codes because, of hypotension that in a cardiac brittle person. All of that goes out the window. All of that goes out the window the second you don't make a healthy person sick. And
you're absolutely right about that. I'm just right now in a hospital where we have been doing this kind of surgery, minimal invasive, for a long time. And I had a conversation with the medical, group here. And since we went from open surgery with all those problems to MIS, the ileus is a foreign word for us anymore. taking the patient back for surgery for IND is a foreign word for us, and so on and so forth. But still, I definitely believe in the future. This podcast is about future of the spine surgery. Future of spine surgery is better diagnostic, using AI for consolidated approaches and doing this complex surgery in a surgery center. In my opinion, by people who use the robot and the navigation machine if they need that, but they don't, most of the time, they don't need that because they're better than those machines.
Yeah,
So,
those machines can improve their confidence and improve their accuracy, but I agree with everything you just said. Those are the keys to the future of spine surgery. Also, the culture of physical rehab, physical performance, prehab. I've been part of our journey was focusing on rehabilitation, prepare for your elective spine surgery. The worst time to learn how to recover from a spine surgery is the first 24 hours after anesthesia. You want to show already trained, how your staff messages. I watch your videos. I know that your team knows how to message before surgery. They know how to message after surgery. Exactly. If you have 3 team members who are, why are you doing that? You can't do that. The whole thing goes out the window. You've got to have consistency. You've got to have a process. You have to have a team that's organized and ultimately doing what? Building the psychology of early recovery, because these people are terrified.
Yeah.
And
so what would you see let's say in the next 5 to 10 years, what do you think is going to be the biggest thing from all the things we talked about? What would be the biggest thing in the overall spine?
In spine, I think it's a couple of things, but for the same general direction. I think the pandemic absolutely accelerated the push to outpatient spine reconstruction, decompression, cervical, lumbar, all of the above. I think right now, the endoscopic team is starting to blend with the reconstruction team, which is starting to blend from the old-fashioned team. There's a general convergence right now that I hadn't seen in 15 years, that I'm starting to genuinely see right now. The capability of clinical pathways, the payer systems are starting to adapt to outpatient spine surgery. Medicare finally is in the process of schizophrenically adding and subtracting coverage every 3 months, but they're close. They're almost there.
I hope you're right about that, because elderly who are on Medicare are the group of people who are most in need of the spinal.
I'm in Florida. 50% of my outpatient is Medicare people. They're the people I really don't want to take to the hospital. And we have the confidence that, look, if they develop a medical consequence, we can simply ship them for inpatient admission, and we can do what we have to do to handle it. But for all of those people that don't have a medical complication, which is 100% of them typically in a given year, we never subject them to any of the hospital-based risks. But we're literally 800 meters from our hospital. So
What they say, hospital is the worst place to be, except if you absolutely have to be there.
And then you need it. And then you need it.
But so I see we agree on that. Now we are getting toward the end of the time here, but I like to stop and talk about another thing that people will hear a lot. You and I are neurosurgeons. We are trained in the macrosurgical technique with the macroscope and so on. And believe it or not, about 9 months before Dr. Kambin died, I had an interview with him. And we talked about his development of the endoscopy, which was a US-grown technology.
Right.
But it didn't get accepted here. It had to go to China, Japan, Korea, and then come back in pieces. But when he and we talked about that, he's an orthopedic surgeon. They never were as neurosurgeon involved in actual microscopy. But he used the urology endoscope for extraforaminal transcambine approach to the spine. Everybody hears now about the endoscopy. And this is yet another tool. That's how I see that. Where do you think endoscopy is superior to macroscope, because you and I, we have been using macroscope for 30 years, 40 years. We have been using long before anybody knew about this macrosurgical technique on the other side. I'm talking about, orthopedic side, that, now they used to do this discectomy, not microdiscectomy, but we have been using macroscope for a long time. So, but I think it's just fair to say each tool has its own place. Where do you see the advantage of macroscope versus endoscope and vice versa?
So if I were me in 1995, starting right now as a neurosurgeon, I would absolutely learn endoscopic spine surgery with a platform and a foundation of microsurgery. I think, endo or is actually, a little unrealistic, because there are absolutely reasons where an endoscope is not ideal. And you get a little too much in the tribal arguments when you argue with some of the zealots. And
zealots, that's good name. Go ahead.
It's like the laser thing. Sure, I could sit there and burn the bone for 6 hours, or I could take a direct visualization, perfect angle of attack, microsurgical approach, 85,000 RPM drill, and do it in less than 20 seconds. The endoscopic drills aren't as adequate. The irrigation is a little irritable. It's hard to get around corners with confidence. You have to be truly a master to deal with certain pathology. The messaging is that it's this or that. The problem is, I would argue, less than 5% of the endoscopic market is capable of doing the advanced cases they show. And because I see a lot of failed endoscopic surgery, where you don't see anybody ever getting anywhere close to the surgical target. Because why? Because thank God they did no harm, but they realized that they couldn't get there and they aborted. But they don't say that. Nobody admits that.
So, but they showed the two pictures where you see beautiful anatomy, not all those pictures that blood, even a little blood or a little, smoke, obscure the entire view, and you are practically operating blind. Now, what I can tell for sure, having approached both of them, is that when I use my microscope, I use an 18mm tube, and I have two hands. I use two tools. And the macroscope, more than the magnification, it brings the axis of my eyes closer, so I can look 3D on the bottom of the tube, and I practically put myself in that position with two hands, whereas with the endoscope, more or less, you have a 2D view, and then most of the time, your one hand is just stabilizing the endoscope, and you're like a one-eyed, and you have to fight that. So in the interlaminar space, honestly, I don't see any advantage to endoscope. Now, having said that, the way it was designed by Cambin, meaning extraforaminal transcambin approach, the macroscope, that throw of the macroscope would be too long, too far. And so for extraforaminal, I do see a very good indication of endoscope. But honestly, it's as you said, unfortunately, lots of people, they think it is microscope against the endoscope. And if you're endoscopic, you're not the macroscope. And I think then you're giving up on something that's proven. And we know in 95% of the cases that you go with the microscope, yes, you cannot look around the corner, but even that might be not the case, because I do laminotomies where I go.
Yes, I always will do a tail of a foraminotomy in a non-deconstructive way. How you do your bone work decides whether it's going to affect stability or not. And with a microscope, you can do that fairly easily. With an endoscope, it's harder. I agree with you. Extraforaminal disc herniation is a great endoscopic. A thoracic disc herniation, lateral, paracentral, is a great indication. Soft, really difficult. Sanjay Geisinger does a brilliant job, and I've seen him show some calcified discs that I was amazed at. But in general, for most people, it's really, really hard. But soft thoracic is a great application. Big free fragment in a young person with a big interlaminar space. That you just grab it and you pull it and you're done. Okay.
Yeah.
Sign me up. but complex, advanced degen, critical stenosis, facet, hypertrophy, ligament, collapse, three-dimensional, hyperlaminar. That's micro. And we know that because why? Because the standard is there any bearing on being able to walk the person out of the facility 2 hours post-op? No.
Yeah.
They all get up and walk out.
Yeah. Now we are getting toward the end, but I would love if you could just for a few seconds talk about XX. What is it?
XX is the next stage of IMAS, where we're taking every surgeon, every surgery, and we're trying to scale the microanalysis of every piece of the surgical execution, not only relative to organization of tools, equipment, trays, sets, orientation of the room, anesthesia, but build the teams around the surgeons. I think one of the neglected components of extreme surgical performance is the pit stop, if you will. And everybody looks at the F1 pit stop and oohs and ahs. Well, I don't think most non-healthcare people understand that healthcare is not an F1 pit stop. And I want it to be an F1 pit stop. And I think every great surgeon deserves a best equipped team. And so I am laser focused on improving the logistics, the organization, the performance, and raising the C for the circulating nurse, for the scrub tech, for all of the enablers so that surgeon can live in perfect flow state, execute his focus at the highest level, zero frustration, running downhill. Effortless surgery is great surgery. And effortless surgery,
fantastic example. They're comparing it to pit stop. By the way, Amanda, do you know what a pit stop is?
Yes.
Some people are like, I didn't know what pit stop is until recently. But what do you understand under the pit stop, Amanda? What do you think?
My understanding of a pit stop comes from the movie Cars, the Disney movie. A pit stop.
Perfect.
Then you know it.
Exactly. Where you go get your lug nuts tightened, everything, make sure everything's working well.
But the harmony, that is the point. The harmony of these multiple people doing a complex job and their efficiency. I think that is what every surgeon strives.
Yeah. You can have a terrible pit stop and the world's best driver, and guess what? You're still going to lose the race. Surgery is measured on speed. Racing is measured on speed. Surgery is measured on focus, on outcome, on efficiency. And if you're poorly organized, how focused are you? How frustrated are you? How clear are you? If you're improvising because you're impatient, and needless to say, personal time and dead time and a time in between surgeries, and how do you manage your personal life? We talked in the previous podcast about balance. Well, how are you going to optimize balance in your lives, in your families, in your physical health and well-being, in your clinic, man? How many times have you been in a surgery and said, oh man, I still have 2 surgeries left. I've got clinic after that. You don't have this. What do you mean you don't have this? I've got clinic. And what does a surgeon not want to be doing when they're operating on someone who has planned their whole life for this moment? You don't want to be rushing because you have 20 other things to do. And so
you need support. You need a team. You need a pit stop team.
So we're going to build the world's best damn pit stop team ever created and imagined.
Wonderful.
I bet that's going to be music to a lot of surgeons' ears.
I think so.
Team.
We're feeling that.
It has been a total pleasure, Robert.
No, thank you for having me. I know it was a lot of stuff. I'm sorry if I go on tangents.
No, I absolutely enjoyed that. And I think any young surgeon should listen to this podcast because they will find some of the experience you just shared with us in their own personal life. So I'm hoping that we will have an impact on future generation with this.
Oh, I'm absolutely sure you will have an impact on future generations. Keep it up. Proud of you and thrilled to be part of it. And I've enjoyed this. Thank you. You're welcome. Please come visit us.
Well, Amanda, we are going to Orlando.
We actually already, I mean, we do have plans to come to Florida in November. So maybe we can, if you're not busy that time, maybe we can come and see you.
Okay, no, just as long as we organize it, it'll be perfect. Yeah, in early December, I go to Nepal on a mission trip where Richard Wones in Seattle invited me along with Richard Chu and Ernie Braxton, and we're going to do a Nepal mission trip. So
Oh, so what are you going to be doing surgery in Nepal
yeah,
then?
yeah,
Wow.
we're going to in 10 days doing surgery and training the Nepalese Spine Society. So
That's wonderful. Well, yet another aspect, another view on your life that we haven't even discussed yet. But it has been a pleasure.
Likewise.
Come to a conclusion, Amanda.
Thank you guys for watching. This was Essence of Medicine, the future of spine surgery. I'm Amanda Armagast.
I'm Dr. Abbasi for Essence.
And Robert Masson. Thank you, everyone.
Thank you very much.